Hello, I am Dr. K. Paul Staller, concerned about the euthanasia program in Canada. Since the federal government legalized medical assistance in dying in 2016, tens of thousands of Canadians have chosen to end their lives with medical help. By one estimate, around 90,000 deaths since legalization, and in 2024 alone, one source projects roughly 16,500 assisted deaths. Official government data show that in 2022 there were 13,241 MAiD provisions, representing about 4.1% of all deaths in Canada that year. In 2023, that figure rose to about 4.7% of all deaths. MAiD is defined as a health service allowing persons who meet strict eligibility criteria, including suffering from a grievous and irremediable medical condition, to receive assistance from a medical practitioner in ending their life. Initially, MAiD was limited to persons whose death was reasonably foreseeable at the time of the request. Since then, the legislation has evolved and expanded. When you look at the data, several patterns emerge. The average age of individuals receiving MAiD in 2022 was around 77 years. The most common underlying medical condition cited was cancer, about 63% in 2022, followed by cardiovascular, respiratory, neurological conditions, and others. The number of written requests for MAiD has been rising steadily, e.g. a 26.5% increase in written requests in 2022 compared to 2021. These facts help explain part of the story. People with severe illnesses facing limited life expectancy or poor quality of life may choose MAiD as an option, but the story does not end there, because when you dig deeper, other factors begin to appear. What else might be driving the MAiD expansion? Beyond terminal illness, several structural, ethical, and systemic forces may be contributing to the growth of assisted dying. 1. Healthcare system pressures, wait times for specialists, overwhelmed hospitals, shortages of palliative and disability supports have been documented in Canada. Some critics argue that when supportive care options are lacking, MAiD may become a more accessible exit than the long climb of treatment or care. 1. Social vulnerability and isolation. Investigations have found worrying cases where people pursued assisted death not simply because of medical deterioration, but because of social issues. Loneliness, inadequate housing, fear of being a burden. For example, a review in Ontario found instances where lack of adequate supports may have influenced MAiD decisions. In such cases, the choice might be shaped not just by illness, but by insecurity, poverty, or inadequate care. 1. Ethical and policy expansion. The definition of eligible conditions and the scope of MAiD have gradually broadened. What began as end-of-life terminal cases is moving toward inclusion of persons where death is not reasonably foreseeable, and discussions are ongoing about mental illness-only cases, minors, and more. Critics argue that rapid expansion raises safeguards, oversight, and equity concerns. 1. Cost, resource, and institutional incentives. There is some public discussion that assisted death might relieve long-term care burdens, hospital load, disability, and palliative care demands. While the official policy does not frame MAiD as a cost saving, external analyses and commentators have pointed out that massive assisted death growth may intersect with resource scarcity. It raises the question, is assisted dying primarily an individual health service, or is it becoming a system-managed outcome in settings of limited care? So, is MAiD simply about choice or something more complex? Clearly, for many Canadians, MAiD is an expression of autonomy, the right to choose how and when one dies, rather than suffering prolonged decline. But the data and commentary suggest that MAiD in Canada is also deeply shaped by the conditions of life, access to care, isolation, adequacy of support, and the options available. When someone feels they are a burden, lacks housing, or receives no hope of meaningful treatment, the choice of assisted death may seem more like the only option. Euthanasia should always be an option, but not a default option, because there are no other options in a society that should have provided those other options. This leads to two important considerations: equity and support. If MAiD becomes available but palliative care, disability support, housing, and social care are underprovided, then those who are vulnerable may disproportionately find their path to assisted death. Normalization and scope creep. When assisted dying becomes increasingly common, when eligibility broadens and oversight is stretched, society must ask whether safeguards are sufficient and whether the choice remains truly free rather than constrained by circumstance. Canada's MAiD program represents one of the most rapidly growing assisted dying regimes in the world. On the one hand, it offers relief, dignity, and choice to individuals in profound suffering. On the other hand, it raises difficult questions. Are endings chosen because the system fails to provide meaningful living? When death becomes accessible, does life become less supported? Both Canadians and the world must keep asking these questions, not in fear, but in care. Because the worth of a society may be judged not only by the freedom to die, but by the freedom and support to live well until the very end. To do otherwise is to create a slippery slope where something that was meant to ease the transition of those already terminally ill and in pain becomes a tool of the state to eliminate undesirables and perhaps organ harvesting. Is this the world we want to live in?